Welcome everybody again after our break. We will start now with the next session, which is an industry-sponsored lunch symposium on new technologies in chest CT. I will be the first speaker, so I'll announce myself. My name is Matthias Prokop from Nijmegen in the Netherlands, and I will talk about ultra-resolution CT for the lung and provide you with an idea of what that technology actually means and some of the clinical experience we have so far. Here's the basic disclaimer that I'm speaking for myself and not for Canon, who is the sponsor of this symposium. And here's my disclosures in terms of research support and departmental support. Okay, now let's go to the basics of spatial resolution in CT. If you look at the resolution in CT, it depends on a couple of factors. Number one is the number of unique rays that we send through the patient. And actually we send a continuum through the patient and we make it into rays by putting a detector behind the patient. So the size of the detector elements defines the number of detector elements and the number of projections. The number of projections is actually the speed at which we are reading out our detector elements as the detector circles around the patient. The other thing is the thickness of the rays. Again, that's depending on the size of the detector element, but also on the source of the X-rays, namely the focal spot size, and it also can have to do with the detector response function. So in other words, if you have a detector that is very sharp in distinguishing a signal or whether it has a somewhat blurred response function. And then finally, and that is what we are using in our clinical practice all the time, the filter kernel. We're using soft tissue filters that have a lower resolution for the mediastinum and high resolution filters for the lung. And recently, iterative reconstruction has arrived, and we'll see later also model-based reconstructions that are no longer iterative. Now, one thing that we all have to realize, and that holds true for CT, but especially for MR, because in MR, resolution and pixel size are basically used interchangeably, and that's total nonsense. Pixel size is actually something that is determined by the field of view divided by the matrix size. So in the case of chest, of a normal chest, of a field of view of 35 centimeters, a 512 matrix, the pixel size will be 0.7 millimeter. If the field of view is 40 centimeters, the pixel size will be 0.8 millimeter. On the other hand, the spatial resolution is something completely different. It is actually measured as a full width of half maximum in millimeter, or as the modulation transfer function, and at that point certain cutoff points in line pairs per centimeter. Now the full width of half maximum is what we're usually using for the slide thickness, but you could also use that as a way of measuring in-plane resolution. If you do that, you get numbers that are much larger than the numbers are usually provided by our vendors, because our vendors want to show you that you have a resolution of 0.3, 0.15 millimeters, but the full width half maximum is much more larger in the range of 0.8 to 0.9 millimeters for many normal body applications. Here in HRCT, we can bring it down to 0.5 if you have a high resolution kernel. And in practice, spatial resolution in our conventional scanners is mostly determined by the filter kernel. And that is actually a very nice thing that shows you immediately that spatial resolution, matrix size, or pixel size are not the same, because we all use the same field of view for our soft tissue kernel and for our high resolution kernel, and obviously the high resolution kernel has a higher resolution despite the fact that we have the same pixel size. Now what's interesting to see, if you look at the resolution, it depends on the filter kernel, and you can see that the resolution, depending on how you can use it, for example, in the brain, if you use a sharper filter for CTA, you can go down to 0.6 millimeters, but our normal brain images have resolutions in the range of about 1 millimeter. The pixel size with a 25 centimeter field of view is 0.5 millimeters. So in other words, the pixel size is beyond smaller than the resolution. There's one exception, and that's actually high resolution imaging of the chest if you use a high resolution filter kernel. There actually our field of view or our matrix size is actually a limiting factor. And there's also the reason that in the good old times of Nestor Müller in the 1980s and 1990s, we would reconstruct one lung at a time in order to optimize this pixel size. We no longer do that because we're all lazy and we don't have enough time. Now, if you look at the resolution of our scanners, they used to be actually depending mainly on our filter kernel and not so much on the radiation dose. This actually changes if you're using the most modern iterative reconstructions, like the model-based iterative reconstruction, and for Canon, that's called FIRST. And what you can see is that at a higher dose, actually the resolution of these techniques actually improves. And you can also see that even at a normal dose, it actually is higher than what you can see by the earlier generation iterative reconstructions like this ADA 3D or filtered back projection. So what we now see is that with our newest techniques, and that's independent of the vendor, we do see that there's a dose dependence of resolution. And actually, if you go to very low doses, our resolution will drop. And in my clinical practice, I see some vendors that actually go very low in their dose, in their clinical routine, and the result are really, really lousy pictures because you go down with your resolution. So you choose your dose wisely because your dose will give you the resolution you need. And that should determine those that you're actually using. Now, resolution becomes dose dependent with these things, and here's an example. Here, an example for Canon and for Philips, iDose and IMR. You can see that with IMR, which is a model-based reconstruction, you see the resolution goes up, and here for the Canon variation, ADA, and here FIRST, you can see the resolution goes up quite dramatically, and you can see here the soft plaque within this carotid stent. Again, a situation that shows you how strong these effects are. Low-dose CT, filtered back projection, second generation iterative reconstruction, high resolution kernel, you see actually a substantially improved image quality, especially in these areas where we have a lot of streak artifacts, and quite sharp delineation of these structures. But if you compare that to filtered back projection, the spatial atelectasis has a minor blur. And if you now use iterative reconstruction, you can see that this blur goes away and the image quality becomes even better. And if you go and enlarge that, you can see that over the second generation iterative reconstruction, these model-based iterative reconstructions actually bring out even more spatial resolution. And that also helps, of course, when you go to really ultra-low dose here, 0.2 millisieverts. Now, the question is, how can we go beyond the resolution of today's scanners? We have a couple of options. One is mode projections, which would mean that we have a faster detector readout so that as the tube circles around the body, we can read that out more frequently, or we have to rotate slower so we can read out the same readout speed, but have more projections. But anyway, these things are implemented in most scanners anyway, so we're not focusing on that. Other things are smaller detector elements, and you can do that by just blocking part of the detector. We can use photon counting or smaller detector crystal. Now, by blocking half of the detector, we're actually making the effective detector element smaller. But of course, we're kind of throwing away half the radiation dose that goes to the patient. It can help in some areas, and it's mainly used for the inner ear and gives you really good image quality, but at a relatively high dose. Photon counting is something that all the vendors are now working on. It's the direct conversion of each photon into a signal, and the detector counts actually each photon and actually can even estimate the energy of this photon. You can put it in different energy bins. And in theory, it should have a super narrow response function. That's at least what Willy Calendar says, but the reality is slightly different. It's a response function that's narrower, but it's not as ideal as you would like to see. The problem with these detectors, and that's the reason why we don't see them in clinical practice yet, is if you give too much dose to a detector element, it will saturate and do nothing. And that means you lose, once you basically have saturated your element, it's saturated, and it stays there towards the end of the scan. Not a good idea, so you need to overcome this problem. But if you do that, you can get really some spectacular images and get good results, for example, here again in the inner ear. If you look at the spatial resolution, however, the way it's implemented at the moment, a standard energy integrating detector is still slightly higher in resolution than a photon counting detector. Now, the last way of doing things is to use superfine detector grids so that the effective detector element size goes down from about 0.5 millimeter to 0.25 millimeters. In order to do that, you have to reduce the dead space, so the septa between these elements have to be super thin to make sure that you're not really irradiating the septa, just a little bit like the lead grid, but that actually can be neglected. And you need, of course, new detector materials and more rapid readout. And also super small focal spots. In order to get these, you really have to make sure that you're not blurring it at the source, at the X-ray tube. Now you get here an idea of what Canon detectors look like. They put this Canon logo underneath, and it shows you what that pixelation actually means. It means that you can see much sharper, and an 0.25 by 0.25 millimeter grain is about the size of a grain of salt. Here's an example where we see ultra-high resolution CT of one of the most modern cochlear implants, which have really super tiny electrodes, and on a normal CT that actually blurs, even if you use a high resolution mode, but with these new detectors, you actually kind of nicely resolve those. And if you look at the modulation transfer function, you see that the ultra-high resolution detector actually has a substantially better resolution. And I put the 50% of the MTF there because that's what we're usually using for our clinical practice. If you use the numbers that we're seeing in our vendor prospectus, which is usually 4%, that's a nice number, sits down there somewhere. But the problem there is that only helps you if you have a super, super high contrast. If you have a reasonably moderate contrast, it's a useless value. So for soft tissue, 50% is good. For lung, it's probably in the range of 20%. And it means we have a resolution of 2 line pairs per millimeter, which is coming close to what we have for normal chest X-ray. Now, this Canon solution has, like all of these high-resolution solutions, one little problem, and that's dose. With filtered back projection, we have a big problem, and that means that if you would like to increase our resolution in 3 dimensions by a factor of 2, then it means that we would need 2 to the power of 4 more radiation dose in order to get the same signal-to-noise ratio, which means that we would have to, in theory, increase our radiation dose by a factor of 16. We've discussed a lot about that this morning. It's probably not acceptable if our patients get this amount of extra radiation dose. So we have to do something in order to overcome that. So the question is really, is higher resolution impossible because of those issues? So the factor that needs to be done is to make actually something that seems impossible possible, and the focus has to be put on reducing noise. And we can do that in 2 ways. We can reduce the noise itself, and we can reduce the noise perception, so the noise that we see on the images. One is by using better detector systems with higher dose efficiency, and the most effective one would ultimately be photon counting, have less electronic noise, and use iterative reconstructions or even more advanced reconstructions that allow you to kind of control noise effectively. The second one is to reduce noise perception by improving contrast by using low kV scanning, using harder X-ray beams, and optimizing contrast injection. Now, in order to get it going, you really need to redesign the whole scanner, and Canon has actually done that. They have optimized tube pre-filtering, use an ultra-small focal spot. If you consider that a normal focal spot is considered small if it's 1 millimeter, this is substantially sub-millimeter. You have a patient table, and this table has to move vibration-free at this sub-millimeter level, which is a massive engineering feat. And for image reconstruction, you would like to make sure that you're not throwing out information. So scatter suppression moves away from massive scatter grids to more numeric scatter suppression, using detector binning for normal resolution modes in very big patients because you would over-radiate them, and use deep learning-based image reconstruction to get optimal image quality. Now, applications could ultimately be quantitative imaging, and we've seen applications using normal scanners for example, the pulmonary vasculature as an indirect sign for emphysema, but also for pulmonary fibrosis. And these vascular structures that we see here are probably going to become more and more important in the future, much more than we think now. And probably there we will see a lot of the problems that's going on in the lung, not so much the parenchyma itself, but the associated vasculature. You can also look at COPD quantification, like looking at the bronchial lumen or the bronchial wall. Resolution here is really, really important. And actually, by using those 2 things, we can actually predict whether someone has COPD with an ROC curve or area under the curve of more than 0.9, 0.91 we achieved, which basically means that you can predict from imaging whether someone has COPD. That sounds not very classy, but what's interesting, it means that we now can say this lobe is actually contributing that much to your COPD, and that lobe contributes that much. That is something that's totally impossible if you look at what we're doing with our conventional lung function. Here are some ultra-high resolution CT scans with patients with bronchiectasis, where you can see all these tiny structures in the periphery of the lung. And this is a scan with a high resolution mode and a 6.2 millisievert dose. In order to give you an idea how it looks, one of the problems that we have is, since we're using that scanner, we use it on all our lung patients, and we get used to it really, really quickly. So we have reset our image quality, but it's interesting to go back and look at some of the older cases. This is a high resolution CT on a 512 matrix 2 years ago on a conventional scanner. What you can see are some cystic lung changes, some areas of probably air trapping, some probably nodular changes here and there. Now this is the follow-up scan, and that has been done with a high-resolution scanner. You see that there is much sharper definition of structures, and if you look at a wider window setting, you see that actually there are lots of tiny little calcifications in this, and this is probably an LIP amyloidosis overlap syndrome in this case. And if you look at the images next to each other, you can appreciate that the amount of detail, especially if, for example, looking here, you can see these tiny calcifications entering this bronchial structure. Similar situation with a patient with emphysema and fibrosis, 512 matrix, follow-up on the ultra-high resolution CT. Everything becomes much more finely defined, and if you put it next to each other, bronchial walls, amount of septa really improves. Does it really change our diagnosis? Very frequently, it will not. It will change, I think, our confidence in what we're seeing, and it will probably change our ability to detect change more probably. And probably another thing is we will need to reassess how we're looking, because at the moment we stop at a certain point because we know that we can't go any further. So at the moment, we really need to think about what to do with these images in the future. I'll show you a couple of more examples here. The classic lung cancer, not too much here, but quite nice images. Again, a combined pulmonary fibrosis and emphysema situation where you could see exquisite detail in the lung parenchyma and on these sagittal images. And of course, in this situation, these patients have a high risk for developing small little things in the lung that turn out to be lung cancer. This is the case in this particular patient as well. Here, patient with heart failure, you can see the dilated left ventricle, increased trabeculization, and here's air trapping. Again, exquisite detail of all the tiny structures in the lung. Bronchiolitis. What we do see here is areas of massive thickening of the bronchi here on an MIP image. What we can see here up to the periphery, we see the thickened bronchial wall, and we see the mucus plugging in small peripheral branches. Again, will it change our diagnosis? In many cases it will not, but there will be cases where we do see added value. One of the problems that we run into, however, is that we're more prone to pulsation. So at the moment, Canon is working on pulsation suppression, because if you have a pulsation of, let's say, 1 or 2 millimeters at a resolution of 4.25 millimeters, you run into a problem. So pulsation is one of the enemies of these ultra-high resolution scanners. It's not much more an enemy than for conventional CT, but it ruins the high resolution that we otherwise could get. Another case with a lung cancer and pulmonary emphysema and fibrosis, where you see, if you look closely, small little bronchus running into this nodule here that probably arose from one of those cystic spaces. You can see these tiny septa in this area of ground glass that shows that this is actually fibrosis. And if you look closely, and unfortunately I haven't shown you a minimum intensity projection, you would also see whether this is honeycombing or not. A case example of alveolar sarcoidosis, where you see these patchy infiltrates, but if you look closely, you now see actually the tiny nodules that make up these infiltrates from this sarcoid. Here again in a different areas and a couple of larger nodules that actually look malignant but aren't in this particular case. Classic sarcoidosis, maximum intensity projections, we see these tiny little nodules along the fissure, and again, on these thin sections, very well-defined larger nodules that we are used to seeing. Things that used to be ground glass now turn out to be clusters of tiny little nodules that we find in the lung. If you have that, it's clear. If you would only have that, it would become much more difficult to make the right diagnosis. Here are coronal images. And also, of course, because of these newer deep learning-based iterative reconstructions or reconstructions, what we can see is that we're getting the noise in the mediastinum under control. Same patient, actually it's the same data set, it's not even a different, it's a different reconstruction, it's the same window. We can see here enlarged lymph nodes in the mediastinum, and you can see the exquisite detail of the bronchial arteries in this particular patient. Thyroid cancer, we know that we have small little nodules. Here we can see submillimeter metastases all over the lung in this particular case. If you look at, Now, another example, lymphatic spread of renal cell cancer, where we see some of the classic features, but if you look very closely, unfortunately I don't have a movie because I don't believe in those presentations, but what you can see here where the little arrows are, this is actually infiltration of tumor in peripheral vascular structures, and you can see that here on the MIP a little bit better, that actually it's not the bronchus, but it's the vascular structure where we do see tumor infiltration in there. And here's again a deep learning-based reconstruction where we do see in this patient with scleroderma a diffusely increased density of the lung with a dark bronchus sign, but also exquisite details of things that in this situation is not really relevant, but it shows you the resolution. This is a small area within the lung, less than a secondary lobule, with a central bronchial and arteriole, which you can depict on these images. And if you look at the noise in these images, despite the fact that we have now ultra-high resolution and a dose of less than 3 millisievert, we actually have exquisite detail in the lungs. So to summarize, in order to get ultra-high resolution CT for the lungs, we need optimization of the whole imaging chain. So from the tube with smaller focal spots, tables that are vibration-free, detectors that are super efficient and have super thin septae with small elements, and new reconstruction engines, we get excellent image quality. And convolutional neural network-based reconstructions actually allow us to do high-resolution imaging at a reduced dose compared to conventional CT. Most of the images I've shown you were still iterative reconstructions. The last ones, a few, were these convolutional neural network reconstructions. The image quality compared to normal CT is, of course, superior, even if you would use high-resolution mode there. And we expect that, especially in areas of fine reticulation, where we have to distinguish between possible and definite URP, it will be helpful. The same for bronchial assessment of the bronchial arteries, or for further assessment of nodule morphology, not so much by humans, but ultimately by artificial intelligence programs, where resolution will really help us identify morphologic features to a much more precise extent. And then tumor station with the question of invasion, where I haven't shown you very much. We do not really know how much the diagnostic confidence will increase and whether there's a change of staging or management. These are questions that we have to look at in the future. What we've seen in our institution is that you get used to these new scanners very, very, very rapidly. And when you look at images from the past or from other sites, you realize how different the quality looks like and what you have been missing in the past. And with that, I thank you for your attention.